Hi, this is Dr. Nick with the ECG Academy, and this tutorial is an essential one. It's dealing with assessing wide QRS tachycardias. Now, this is one of the most common problems that people face on a cardiac unit, looking at a wide QRS tachycardia and trying to figure out, is it non-sustained ventricular tachycardia, or is it some kind of atrial arrhythmia with aberrancy? So we're going to discuss all these points that you should be using when you're assessing whether this is atrial or ventricular. You have to look for changes in the QRS morphology, examine how did it start, and whether there's a P wave that initiates the arrhythmia, or whether you can look for fusion beats at the beginning. Decide how premature was the first beat, and can you explain aberrant conduction, because functional aberrancy only occurs with rapid or premature beats. I'll show you how to look for AV dissociation, and you have to look at the big picture. What context did it occur in? Was there AFib underlying? And does the arrhythmia fit this aberrant phenomenon known as Ashman's? So let's quickly review what happens during the cardiac cycle. Of course, the sinus node fires and gives rise to a P wave. The signal gets into the AV node, is delayed for a split second, and then normally would go down both bundle branches simultaneously, giving us a nice narrow QRS complex and a T wave with repolarization of the ventricles. But you have to recall from my lesson in IVCDs that one bundle branch may have a longer refractory period than the other bundle branch, and if one bundle branch or part of the conduction system recovers sooner than the other, well then if the AV node lets a signal down right at this moment, when the green conduction system has not recovered, then that part of the conduction system will not be able to depolarize and will block. But the part that's drawn in purple has recovered and would be able to fire, but the green will just not get a response. And so what happens is with a premature or rapid beat, one of the bundled branches may block, but the other will be able to conduct the signal, and you'll wind up with a wide QRS because of slow intramyocardial pathways that have to make their way around the rest of the heart. So this idea of functional aberrancy is very important, and that's generally why the QRS gets wide. But the point is the QRS complex changes when you have some kind of aberrant conduction, and it also changes if the beat arises from the ventricle. If you have a focus down here that starts firing, the signal may get to one side of the heart very quickly, but then have to travel through slow intramyocardial pathways to get to the other side. And that's why ventricular arrhythmias are usually associated with a very wide QRS complex. But what if it arises from somewhere in the septum? Then it may engage part of the conduction system, and so you can't rely on the QRS width. In other words, ventricular tachycardia doesn't always look this way. It may be just a little wider than the normal conduction system. And that's why people who rely on just the appearance, when they examine a strip and they say to themselves, well, gee, it looks like VTach, that is a prescription for the wrong answer. So don't rely on wide, really bizarre-looking QRS complexes. I'll show you examples of when it doesn't look that wide, just a little different. So let's take a look at some examples and try to come up with an organized way to approach it. So here's the first example, and what you see are a couple of normal sinus beats here in the beginning, and then you have this tachycardia at a rate of about 160 beats per minute, and it's a little bit irregular, but the QRS complexes clearly look different than the underlying QRS complexes, right? But it is irregular, and it did start kind of late. Look at that. It started so late that, in fact, you can see a P wave in front of it. Look at that. There's a P wave. Here's a P wave. And this P wave occurs on time. It's a P wave that's on time, but look at the PR interval. Look at this compared with this PR interval. It's much shorter than the underlying PR interval. And the QRS is clearly different. Now that PR is so short that this P wave could not have possibly gotten through the AV node. Remember, the AV node delays the signal, right? Why would the AV node suddenly not delay the signal? How could this P wave suddenly get to the ventricles early? Well, the answer is it didn't. That this first beat had to come from somewhere other than this P wave. That means it's ventricular. And of course, they all look alike, so they all must be ventricular. Nevertheless, the person on the unit marked this as 3-second run of AFib, which brings in mind Tulow's law. Don't ever believe anything you read on a rhythm strip unless you wrote it yourself. So this is not AFib, it's non-sustained ventricular tachycardia, purely because of the way it started. First of all, why would this first QRS be aberrant? It wasn't very early. You cannot say that this is a functional bundle branch block because it didn't come early. So that doesn't support this being aberrancy. And the most important thing is, of course, this first QRS did not come from the P wave, so it came from the ventricles. The other thing that you can see, look at this ST segment and then look at this ST segment. What you see there is a dissociated P wave. There's a P, and in fact you can see a really tall tip on this T wave compared with this one. So those are dissociated P waves because you have some degree of retrograde conduction from the ventricle back up to the atrium. So this has all the hallmarks of ventricular tachycardia, despite the fact that it is a little bit irregular and the QRS is not that wide. So don't use width or irregularity to decide whether something's atrial or ventricular. Here's the next example. Here you have 3 simultaneous leads, and you have 2 wide QRS beats and then a narrow one. So the question is, are these atrial or ventricular? And what you need to do, first of all, is say to yourself, well, okay, this did come early, so it could be aberrant. So let's see, how did it start? Where are you going to look for the P waves? Well, you're going to look for the P wave in front of this QRS complex. But generally, when you have a premature beat, you've got a T wave. And so therefore, you have to look for a P wave superimposed on a T. And the way you do that is to compare the T waves of the last couple of beats. Look at how nice and smooth those are. And now look at that T wave is distinctly different. Look at that tall peak on this. And you can see again here, this is a nice smooth T wave, whereas this one has a sharp spike on it. It's like Mount Everest over here. So this is the premature atrial contraction that conducted with a fairly long PR interval here. Why? Because it was early. Premature, right? It was early, and so it landed at a point when the bundle branches had not recovered, and you have functional aberrancy. You have a bundle branch block, and somewhere in here you can find a second P wave that gives rise to the second QRS complex, which looks very similar, so they're both aberrant, but then there's another P wave here that manages to get down both bundles at the same time, and so the third QRS is narrow. But what you have here is an atrial triplet. It's atrial, because you can see it started with a P wave, had a little bit of first degree AV block, and then you have this functional aberrancy that made the QRS wide. Remember, T waves have a very slow change in voltage, very low frequency signals within that T wave, but P waves generally tend to be sharp and spiky with a higher rate of voltage change, higher frequency components. And so when you see a T wave with a bump on it, or if you see a T wave with a bite taken out of it, that's usually indicating that there's a P wave superimposed on the T. And that's really key because most people don't look for P waves when they're assessing this wide QRS tachycardia. The rest of this discussion will be on part 2 of assessing wide QRS tachycardias.